Dr. G. Prasad Rao, Director, Psychopharmacology and Schizophrenia Division, Asa Hospital, Hyderabad. He has received Dr. S. Pinakapani Gold Medal in Medicine. President, Indian Psychiatric Society, Editor, Indian Journal of Psychiatry, President, Indian Association of Geriatric Mental Health, President, Indian Association of Private Psychiatry, President, Society for Bipolar Disorder of India, President, Indian Association for Biological Psychiatry, President, elect an Asian Federation of Psychiatric Association. I invite Dr. S. Neelagandan, MBBS, MD, Consultant Psychiatrist and Child Specialist, to honor our chairperson, Dr. G. Prasad Rao. Thank you so much, Dr. S. Neelagandan, sir. Now over to the Dr. G. Prasad Rao.
A very good morning and greetings to this holy city of Madurai and to this wonderful conference, the 54th of our Indian Psychiatric Society. I deem it a great privilege with CRS, my elder brother, sitting right in the front. Let me wish happy birthday to CR Ram Subramaniam. And may we celebrate his birthday all through year over year. Now, over the years, I think if you minus out the atypical antipsychotics over the years, really we did not have any new molecule. And what great happiness we have when the new molecule is kind of discovered and invented by our own country. I'm talking about Endoxyme. The times have come when we are looking for molecules for our difficult patients. And bipolar disorder, I've been part of the panel in the World Federation as well. You asked Lakshmi Yatham, the current president of the International Society for Bipolar Disorder and also the World Federation of Biological Psychiatrists. He is cautiously optimistic. And when we had him in our panel to discuss Endoxyme, he actually suggested that probably this is breaking the ice. Now this is my proud privilege also to introduce that the new topic is looking for molecules, the current new molecules in the bipolar disorder. The old molecules had their great life, they continue to have the life, especially lithium and divalproate. But then atypical antipsychotics have become a kind of close in terms of efficacy, but safety issues matter. And that's the time when, way back in 2015-16, our own country has started research, and the first publication came in 2016 on Endoxyme. We are also proud that the Indian bipolar researchers have done this trial and given the efficacy. Right now, the US FDA is also doing a multi-centric trial in United States. Apart from that, I think I am the lead investigator for about 30 investigators in this country we are doing. But time has come for me to introduce Dr. Suresh Kumar. I have introduced the topic. Suresh Kumar is my dear young friend, a great researcher. He's currently the professor at KMMCT Medical College in Kerala. A lot of experience in psychiatry, but at a personal level, he's a keen researcher, keen observer. He has won many awards. He has been in the academic front, published more than 100 papers, authored 17 chapters in 17 books. A very quiet person, and to my happiness, me and Suresh Kumar are going to chair and continue, and Suresh is going to present the paper. May I now invite Suresh?
Good morning, sir. Am I audible?
Yes, you are audible. Share the slides also.
Good morning to respected chairperson, my seniors, colleagues and friends. Thank you, Prasad sir, for the nice introduction. So the topic for me to present is recent updates on bipolar disorder management with a special focus on the new molecule Endoxyme.
Sir,
Can
we
I
can't.
start sharing the slides?
Sir, please, slides, sir. No, sir.
Okay.
Share the slides, please.
Yes. My slides visible now?
Yes, they are now present.
Okay. So, as Dr. Prasad Rao sir said, bipolar disorder, it is not a difficult, it's not a very easy thing to manage every bipolar disorder. We know that in depression, in mania, and when we look at the bipolar disorder as a spectrum altogether, there will be 10 to 15% of the cases will be treatment resistant. See, whatever the drugs which are available in our psychiatry armamentarium, all these drugs we can say that these drugs are not completely, it is not 100% effective. Many of these drugs have got their own side effects. Many of the drugs are not much effective. So we are always on the lookout for new molecules to find out an ideal mood stabilizer which will prevent the recurrence of mania, which will prevent the recurrence of hypomania, mixed episodes, and also to prevent the recurrence of depression. And it's also, there should not be any side effects with the mood stabilizer. Such a unique mood stabilizer, still it is not available, and still we are working on that. See, when we look at the current treatment landscape of bipolar disorder, for the treatment of mania, hypomania, and mixed episodes, 1970, we know that lithium was started. It was approved by US FDA as a mood stabilizer. Now, when we look at 2021, see here we can see that we have got an array of various different type of mood stabilizers, like divalproex, we have got carbamazepine, oxcarbazepine, and now the new introduction we have got atypical antipsychotics. We know that most of these drugs are acting at the neurotransmitter level. When we look at sodium valproate, carbamazepine, oxcarbazepine, etc., all these are not actually, they are not mood stabilizers, they are actually anticonvulsants. But it is also, we can also use it as mood stabilizers. So we can say that these so-called mood stabilizers are not specific to the prophylactic treatment of mania or bipolar disorder. We can also use it as a mood stabilizer, that's all. And when we look at atypical antipsychotics, the actual specific indication for atypical antipsychotics is for the treatment of psychotic conditions. But we can also use it as a mood stabilizer. So we can say that there is no an ideal effective mood stabilizer, still it is not available. So what are the challenges with the current treatment options in the treatment of bipolar affective disorder? When we look at the mood stabilizers which are available in our market, we can say that, see, if you look at lithium or sodium valproate or whatever, whichever mood stabilizer, all these mood stabilizers will take some time for its onset of action. It may take minimum 2 to 3 weeks for its effect to manifest. And many of the mood stabilizers like sodium valproate, it can produce alopecia, tremor, weight gain. When we look at lithium, it can produce thyroid dysfunction. Some people it can produce renal problems. And moreover, lithium, for example, dose titration, drug monitoring is very essential. If the serum lithium level is not within the therapeutic range, if the level is less than the therapeutic range, the drug is not effective. If it is more than the therapeutic range, it can produce lithium side effects and lithium toxicity. So all these are the limitations of the mood stabilizers. When we look at atypical antipsychotics, whether it is olanzapine, risperidone, or whatever, whether it is clozapine, more than, suppose we increase the dose, still there is a chance for extrapyramidal symptoms. And now, olanzapine is notorious for producing metabolic disturbance, weight gain, obesity, hyperglycemia. All these are the inherent problems of the new generation so-called atypical antipsychotics. And many of these drugs, like mood stabilizers, anticonvulsant range, atypical antipsychotics, most of these drugs are metabolized through cytochrome P450 pathway. So many of these people may be taking other drugs, so there is a chance for drug-to-drug interactions also. That is why we are always on the lookout for a new drug, ideal drug, which will not produce any of these complications. At the same time, it should be effective in the treatment of bipolar disorder also. Now, see, there are some new opportunities. The new research data, it suggests that impairment of neuroplasticity, the cellular resilience, that is the main pathophysiology, that is the underlying pathophysiology of bipolar disorder. So the research in bipolar disorder is going beyond the level of neurotransmitter. It is going into the molecular level. So that is why some new studies which have found out that in bipolar disorder, in manic stage, the platelet protein kinase activities increase. So the changes in protein kinase activity, the increased activity of protein kinase may be an illness-specific marker in bipolar mania. The recent research is showing that the protein kinase activity is increased in bipolar mania. So people are doing research in various levels, in various areas at neurotransmitter, molecular level. So we know that tamoxifen is a chemotherapeutic agent, which is an anti-estrogen agent used in the treatment of breast cancer. Tamoxifan's one of the main metabolizers is endoxyme. Tamoxifen is metabolized through cytochrome P450 pathway, and one of the metabolites is endoxyme. It's a metabolically active agent. So this endoxyme is acting at a new molecular level that is beyond the receptor level. That means endoxyme is acting on the protein kinase enzyme, and it is inhibiting protein kinase enzyme. So we know that in bipolar disorder, there is an increased activity of protein kinase enzyme, and this endoxyme is inhibiting the enzyme protein kinase. So why not? People are thinking that endoxyme, when it is inhibiting the enzyme protein kinase C, why not? It may be an effective agent in the treatment of bipolar mania. That's why the research got started. So we are expanding the molecular research into clinical relevance related to endoxyme, and by that we are unfolding the history by going beyond the level of synapses. We are going into the molecular level. See, for the last 50 years, I told you that there are so many challenges with the current treatment regime. Whatever drug which is available in the market, we know that it is not an ideal mood stabilizer. So that is why we are trying to bring out a therapeutically relevant biochemical target which is going beyond the neurotransmitter level at the molecular level. So there are certain criteria for a therapeutically relevant biochemical target. See, for a chemical substance, for a drug to be therapeutically effective, to see that which is acting on the biochemical target, it should be consistently therapeutically effective at a definite plasma level. So the same drug in the same dose should be effective for the same type of illness in all patients. So that is why we are saying that it should be consistent. Then it should be relevant. That means the particular agent should act on the definite pathology which is related to that particular illness. For example, endoxyme, we can say that bipolar disorder, protein kinase overactivity is there. So endoxyme will reduce the protein kinase activity. So the drug should be acting on the relevant pathological basis. Then it should act at a localized brain area. For example, in bipolar disorder, whichever area is overactive or abnormal in bipolar disorder, the drug should go there and should act in that particular area. Then it should be there should be a temporal correlation between the drug administration and the onset of clinical efficacy. So once after starting the drug, the patient should start showing the efficacy. So these are the definite criteria for a therapeutically relevant biochemical target. So see, now previously the pharmacological research was at a traditional level. Many of these drugs, the so-called psychiatric drugs, antipsychotics or antidepressant or mood stabilizers, many of these drugs were discovered out of serendipity. Initially, we will look for the common features of an illness, then what are the priority in the clinical symptoms, and by giving some drug, by manipulating the drug, we will see the response. Then we will see in whether it is acting at a synapse, whether it is acting at a particular neurotransmitter or a combination, multiple neurotransmitter level. Then we will start doing randomized clinical trials. Then we will have clinical data. Then we will see that the drug is effective for a particular condition. So this is the traditional drug therapy. So by that only many of the drugs like lithium or sodium valproate or antidepressants were discovered, and it was found to be effective for particular conditions. Now, when we look at the designer drug development, the designer drug development is first it is happening at the laboratory or the pharma research level. By looking at the various drugs, its effect, its metabolites, its catabolism, etc., whether it is acting molecular level, neurotransmitter level. Then by looking at the laboratory level, then we are going to the clinical application. Then again, we are doing the research whether this drug is effective, or after manipulating the chemical structure, will it be more effective? Then manipulating the clinical structure, will the side effects be less? Like that, we are clinically, we are in laboratory manipulating the molecule. Then again, we are going for clinical application. So that is the usual things which is happening in the designer drug development. So we can say that many of the newer drugs which are developing and developed in psychiatry, which are belong to the designer drug development level. Now, I told you about protein kinase C enzyme, which is specific, maybe a specific illness marker in bipolar mania. So when we look at the protein kinase C enzyme, we can say that there are three main subfamilies for protein kinase C enzyme. We can classify it as conventional, novel, and atypical. Conventional is mainly activated by calcium diacylglycerol and phospholipase. Then novel, which is activated by diacylglycerol and phospholipase. Then atypical, it is activated by phospholipase. So here we are mainly looking at the conventional protein kinase C enzyme. Protein kinase C, I told you that conventional or classical, novel, and atypical. So this classical or so-called conventional protein kinase C enzyme, which is mainly concentrated in prefrontal cortex, hippocampus, amygdala, etc. So these are the main areas actually which is implicated in bipolar disorder as well, whether it is depression or mania. These are the main structures involved in the episodes of depression and mania. So this classical protein kinase, it has got a short-term effect. When the protein kinase C is stimulated, in the short-term effect, is that there will be immediate neurotransmitter release. Then medium-term is receptor regulation, modulation of receptors. Then finally, the long-term effect is actually, that is what we actually intend to have, that is cell proliferation, synaptic remodeling, gene expression, neuroplasticity, etc. So these are the main effect of a protein kinase C enzyme. We can see this is a hypothetical scheme of the effect of the hyperactive protein kinase C enzyme. So this is activated by phospholipase C. Phospholipase C is dissociating phosphoinositol diphosphate into diacylglycerol and triphosphate, inositol triphosphate. So that will lead to the formation of diacylglycerol and inositol triphosphate. This diacylglycerol, that is a stimulator of protein kinase C enzyme. So once the protein kinase C enzyme is stimulated, what will happen that there will be an increased insertion of protein kinase C on the cellular membrane. Then subsequently, there will be an increased stimulus-induced membrane translocation of protein kinase C. Then that will lead to another cascade of reaction, that is increased Marx phosphorylation. Then what will happen that in the postsynaptic membrane, there will be increased alignment of synaptic membrane, there is increased alignment of neurotransmitter containing vesicles, increased phosphorylation of SNAP25 and increased neurotransmitter release. So what will happen that the stimulation of protein kinase C, in effect, that will lead to increased release of neurotransmitter into the synaptic cleft. There will be simultaneously an increased release of AMPA and NMDA receptor phosphorylation. That also will lead to increased neurotransmitter release. So finally, altogether, this will lead to increased neurotransmitter release. Then, what is the role of protein kinase C in bipolar disorder? Let us have a look. So protein kinase C is an enzyme which is involved in the regulation of processes that are affected in bipolar disorder. So that can lead to neuronal excitability, increased neurotransmitter release, glutamatergic transmission, that can lead to neuroplasticity, apoptotic pathway activation, mitochondrial dysfunction, oxidative stress, neuroinflammation. So all these are negative things except neuronal plasticity. So protein kinase increased activity is leading to all these problems in bipolar affective disorder. Then, what are the evolving role of protein kinase C? See, studies have shown that the increase of protein kinase overactivity throughout the brain, that may contribute to the total manic profile. So in a manic patient, because of increased protein kinase C activity, these people that can lead to suicidality. Studies have shown an association between protein kinase C enzyme and suicide attempts. And many of the even first degree relatives of people with bipolar disorder, they also have shown to have increased protein kinase activity. So there is a connection between protein kinase C enzyme in bipolar disorder and susceptibility to this particular condition. Excessive activation of protein kinase can dramatically impair the cognitive function. So that may be the reason for cognitive impairment in during the episode of mania in bipolar disorder patients. So these are the main issues which connected to protein kinase activity in manic profile. So inhibitors of protein kinase C enzyme that may be useful in reducing ethanol consumption, even that is effective in alcohol consumption, alcohol dependence. It is also effective in the management of anxiety. Protein kinase C inhibition that will block the development of cocaine. So there is this is an interested area. So it may be effective in the management of cocaine dependence. Protein kinase inhibitors may be neuroprotective. It is especially in many disorders, we have seen schizophrenia, post-traumatic stress disorder. Studies have found dysregulated protein kinase C signaling. So in these conditions also, maybe protein kinase enzyme inhibitors may be effective. So once this protein kinase C enzyme is blocked or inhibited by the new molecule endoxyme, then all these cascade of reaction will be blocked. then the conversion of P1, P2 into inosyl triphosphate diacylglycerol, then again subsequent stimulation of protein kinase C, and this cascade of reaction will block. So there will be, and the further neurotransmitter release will be blocked, and other associated that neuronal apoptosis, mitochondrial destruction, everything we can block by the direct blocking of protein kinase C enzyme. This is what the research shows. Endoxyme, when we look at the pharmacokinetics, it follows a linear kinetic linear pharmacokinetic profile. When the concentration, when the dose of endoxyme increases, the concentration in blood also will increase. Half-life is around 52 to 58.1 hour. It is not, as I told you earlier, it is not metabolized by cytochrome P450 pathway. So there is a less potential for drug-to-drug interaction. It is actually metabolized by conjugation. It is metabolized by sulfotransferase and glucuronosyl transferase. So these are the enzymes which are involved in the metabolism of endoxyme. Now we can look at the clinical experience on endoxyme in the management of bipolar disorder. See this, here I am showing a phase 2 study. Endoxyme, a new option in mania. This is a double-blind active control trial that demonstrates anti-manic efficacy of endoxyme. This study is published in Clinical Translation Science in 2016, phase 2 study. So here, 84 patients with bipolar 1 disorder was randomized. 71 patients completed the study. And in one arm, there were 27 patients receiving endoxyme 4 milligram per day. And there were 28 patients receiving endoxyme 8 milligram per day. And the comparator arm was divalproex 29 patients receiving 1 gram per day. And after 3-week study, 21-day study, they found that the YMR score improvement was 13, 16, and 16 points in 4 milligram, 8 milligram, and the third one in the divalproex group. So we can say that the improvement is 55% versus 55% in 4 milligram of divalproex, and 59% versus 65 in 8 milligram versus divalproex. So there is slight improvement in divalproex group when we compare patients receiving endoxyme 8 milligram per day, but it was not statistically significant. So the impression is that endoxyme 8 milligram per day, its efficacy is equal to divalproex. So see, when we look at here, divalproex has got its own inherent some problems like it can produce alopecia, it can produce weight gain, it can produce, sometimes it can produce reduction of platelet count, it can produce pancreatitis. So compared to divalproex, side effects are less, the efficacy is equal. That is what we are trying to say. Then, when we look at another phase 3 clinical trial, which is the publication is not still available. It is ahead of print. It's a double-blind, double dummy active control oral multiple dose parallel randomized study to evaluate the efficacy and safety of endoxyme in bipolar disorder. So phase 3 study, we'll come to that in detail. So here, when we look at the methodology and study population, it's a prospective multi-center double-blind active control study conducted in 8 centers in India. The endoxyme 8 milligram versus divalproex 1000 milligram once daily. Total 228 patients were recruited with age 18 to 65 years. The patients were having mania or mixed mania diagnosed as per DSM-5 with a MANI score of IMRS more than 20. CGI score was more than 4, and they have already shown response to lithium, valproate, carbamazepine, and atypical antipsychotics except clozapine. Newly diagnosed bipolar disorder was excluded. So this is the study population. Then when we look at the study design, study as I told you conducted in 80 centers all over India. The duration of treatment was 21 days. Patients were randomized into endoxyme 8 milligram and active control 1 gram per day. And in endoxyme, out of 116, 110 patients completed study in divalproate sodium. Out of 112, 103 patients completed the study. And then we'll come to the results. When we look at the mean change in total YMRS score at day 21, when we are comparing the score from baseline to day 21, see in endoxyme, the mean is 15.59 and divalproate it is 15.76. So there is no significant difference in the mean score from the baseline to 21 day between endoxyme and divalproate. So we can say that the conclusion is that endoxyme is not inferior to divalproate with regard to the efficacy in manic episode. So it is not inferior. Then when we look at the overall YMRS score, the graphical representation also here, T is the test. When we look at the score from day 0 to day 21, here both endoxyme and divalproate, there we can see that there is a steady significant reduction from baseline to day 21. But when we look at here, in the test endoxyme from day 0 to day 21, there is a significant change. In the divalproate reference molecule, also from day 0 to day 21, there is a significant change. So between test and reference, there is no significant difference. That is why we are saying that endoxyme is not inferior to divalproate with regard to the efficacy in manic episode. Both have equal efficacy. There is no statistically significant difference between the two treatments in the mean total YMRS score. Now, when we look at the response and remission between endoxyme and divalproate, here we can say that in the day 2, in the responders in the endoxyme arm, one patient has shown remission at day 2. Remission means response means more than 50% reduction in the YMRS score. So in the endoxyme, we can see that at least in one patient on day 2, the score was reduced by more than 50% in the endoxyme arm. Then when we look at the remission, that means YMRS score is reduced more than 12. So here on day 4, 3 patients in endoxyme arm have shown remission. So there are more number of patients in the endoxyme arm showing early response and early remission compared to divalproate. Then when we look at the MADRS, CGI BP and CGI global impression of severity score, there also, here we can see that the blue one is endoxyme and the slightly yellow one is divalproate. So when we are comparing the MADRS score, severity of illness, change from the preceding phase, change from the worst phase of the illness, severity of the illness, global improvement, therapeutic effect, as well as side effect, we can see that all these are compared between the two molecules. All these are, we can say, comparable. So both are of equal efficacy, side effects wise comparable. So this is the impression which we are getting from the phase 3 clinical trial. When we look at the need for lorazepam or diazepam for these two molecules, the percentage of patients needing lorazepam or diazepam for controlling agitation and akathisia, here we can say that the total number of patients received lorazepam in the study. In the endoxyme, it is 10. In the reference, divalproate, it is 13. So there is no any significant difference. Then the number of patients who received lorazepam prior to randomization. There it is also 8 in endoxyme and it is 12 in divalprox. There is no significant difference. Then the number of patients who needed lorazepam after randomization, again it is 2 in endoxyme and only 1 in divalprox. There is no significant difference. So we can say that in both groups, the requirement of benzodiazepine to control agitation was less and it was comparable. So it signifies that both drugs were comparable in terms of potency and efficacy. Then, what are the observed adverse effects? When we look at the total number of patients, both in endoxyme and divalprox, there were total 100 adverse events reported by 64 patients. In divalprox it was 52 and in endoxyme it was 48. There is not much, anyway there is no statistical difference between the number of adverse events. When we look at the type of severity of the adverse events, majority, 72 patients, it was only mild. Then it was moderate in 27 patients and it was only grade 3, severe in only 1 patient. Now, when we look at the outcome of adverse events, 95 patients outcome, it was resolved, and in 3, it was resolved with some sequelae, and in 2 only it was of more severity. So most of the patients, the adverse events were only mild, and most of the patients, the adverse events resolved completely. So when we look at the adverse events, what are the adverse events in endoxyme arm? So few observed adverse events in the endoxyme arm, they were mainly headache, vomiting, insomnia, restlessness, and gastritis. There was no treatment emergent depression, and there were no deaths. No serious or significant adverse events happened throughout the conduct of the trial. So most of the adverse events were mild. There was no worsening or treatment emergent depression during the course of the trial. Now, some of the few observations we would like to highlight that in endoxyme, when we look at the total number of platelets, there were no significant change. But when we look at the platelet count in divalprox, there was reduction in platelet count. So there were no changes in thyroid hormone level, blood glucose level, cholesterol level that were not observed in endoxyme arm. This is one of the observations. Actually, no specific investigations required for endoxyme. In the phase 3 trial, in the clinical development program, there were all these patients were investigated for liver function test, renal function test, complete blood cell count, ECG, thyroid hormone level. All these were conducted at the baseline level and at the end of the trial, and there were no significant change in any of these parameters compared to the baseline and at the end of the trial. So no specific investigations actually required for endoxyme because there were no significant changes for any of these investigations. However, no safety concerns with respect to abnormal investigations or thrombotic effects were observed during the clinical development program. That is why we are saying that actually when we are giving endoxyme in our clinical scenario, in our real life, no specific investigations are required during treatment with endoxyme because there is no changes with any of these investigations. Now we have to look for a few points. They have to be noted for endoxyme. What are these points? Endoxyme is not recommended for pregnant women and lactating mothers because still we don't have enough evidence that whether it is effective in pregnant ladies and whether it is effective for whether it is safe for lactating mothers. We do not have enough data, so it is not safe to give for pregnant ladies and for lactating women. Women taking endoxyme who wish to become pregnant, they should stop endoxyme at least 2 months prior to conception. Now, when we look at the contraindications, the main contraindication is for patients who require concomitant coumarin type antiviral therapy, warfarin, or in patients with a history of deep vein thrombosis or pulmonary embolism. So for these type of patients, endoxifen is contraindicated. What are the unique attributes of endoxifen? We know that endoxifen is a direct PKC inhibitor. Same time, lithium and all other anticonvulsants are also PKC inhibitors, but they are all indirect PKC inhibitors. So this one is a direct PKC inhibitor. This is a new drug target for acute mania, while lithium and divalproex are indirectly inhibiting protein kinase enzyme. For endoxifen, there is no need for a therapeutic drug monitoring. We know that for lithium and even sometime for divalproex, therapeutic monitoring is needed. No dose titration is needed for endoxifen, but lithium, we know that therapeutic monitoring dose titration is needed. For endoxifen, because it is metabolized through conjugation pathway, because it is not metabolized through cytochrome P450 pathway, there is no drug-to-drug interaction. It offers, from the phase 2 and phase 3 trial, what we have found that it offers similar clinical efficacy to divalproex based on phase 3 trial experience. And few patients, it has shown an earlier response and earlier remission. There is no adverse events like decrease in platelet count, hair loss, tremor, which can occur with the sodium valproate. It will not produce weight gain, changes in blood glucose, or changes in cholesterol level, which can happen with the atypical antipsychotics. There is no changes with the thyroid hormone level like lithium or divalproex. See, we can look at expert comment from one of the global authorities in bipolar disorder. He has opined, Dr. Lakshmi Yadav has opined that apart from monotherapy, endoxifen can also be used in combination with the atypical antipsychotics and benzodiazepine. So it can be used in combination therapy along with the anticonvulsants and atypical antipsychotics. There is a less concern about cognitive problems or worsening of depression with endoxifen, considering PKC's role in neuroplasticity. PKC actually overactivity is producing cognitive problem. PKC inhibition will not produce cognitive problem. It may sometimes improve the cognitive deficits, for example in schizophrenia and all, by promoting neuroplasticity. And another important thing is that any drug that treats mania may also prevent mania. So endoxifen, because it is a good drug, maybe a good drug for the treatment of mania, we can think that it may or can also act as a prophylactic agent. So there is a good chance that endoxifen will have prophylactic efficacy as well. Now endoxifen is approved by DCGI for the acute treatment of manic episode with or without manic features in bipolar 1 disorder. So it has been approved by Director of Drug Control India, and the dose is 8 milligram per day. Thank you for the question.
Thank you, Suresh Kumar. I think that's a fairly comprehensive coverage of the emerging role of PKCs in bipolar. And as I said in my opening remarks, you well covered the importance of PKC, the classical, atypical, and the relevance. I am to state maybe one or two summarizing points. One, it is a clean drug at this point of time. Why clean? Literally thousands of patients were used in cancer therapy. In cancer therapy, this molecule has been used, and and it's a prophylaxis in breast cancer relapse also. So we have data on that. Maybe we have to juxtapolate that to at least observe the side effects, so that way it's a clean molecule. Second, it can be used with all the available molecules today in our armamentarium for bipolar. And it works fast, at least the initial data is showing. Prophylaxis we need to establish, but acute mania, with or without mood stabilizer, it is efficacious. Side effects wise, except dizziness and giddiness occurring in the first few, and which is mild only. I think this is another positive point. The other 2 points which I would like to just state is it works in bipolar mixed. And there is now emerging evidence bipolar with substance use. So with this, I open this session. Thank you, Suresh, for a very wonderful session.
Thank you.
Are there any questions on the online? Meanwhile, I would request any questions from the floor. Yes? Mike? It's Dr. Srivastav.
Anurag Shrivastava from Hyderabad, sir. Thank you for a very comprehensive review of that, sir. Could we go back to that slide where you compared the efficacy of endoxifen with valproate? Is it possible to go back to that slide and have a look at it, sir?
Yeah, he's trying to go back. What about, meanwhile, you can shoot the question?
So what I felt is that from what I remember, at 21 days, the efficacy of endoxifen, it was the number of people who had shown a response was around 49%. Versus valproate, which was 38%. I just wanted to check whether I remembered that right. So basically we are saying that at 21 days, less than half of the people have responded. So the data looks good because valproate is surprisingly only 38% people have responded. But other studies will show a much higher rate of response to valproate. So if less than half the number of people are responding at the end of 21 days, I wanted your opinion on what you really think the efficacy of this molecule is.
Suresh, I think, I think Anurag's comment is, can you show the slide if you can?
Yeah, previous question, they want to show the slide again, no?
Okay, you can read it out if you can. If you are not able to slide show. He wants to just check whether at the end of 3 weeks, the numbers he is checking. Yeah.
Yeah, this is the slide they are asking, no?
Yeah.
Yeah, see here we can see that at the end of 21 days, 3 weeks, definitely we can say that 49, half of the patients have shown response in both the sodium valproate and endoxyfen arm. So that's a very good thing in our clinical experience. Within 21 days, if they have shown 50% of the patients have shown efficacy, that means a good thing. So what we have to say that still say only 220 only limited number of patients who have done the trial. So we need more number of patients.
Anurag, I think his question is answered. See, 49% and 50% is the people who responded at the end of 21 days based on the YMRS scores and CGI together. So that is actually, if you really see in bipolar, most of the studies, the ratio is around this point at 21 days.
Remission, definitely, sir. I feel remission, it's too early to say remission.
No, okay.
But response of 49%. So
yeah,
that
49 and 50. So this is essentially they both are comparable. Remember, this is only 21-day data. Actually, this is a multi-centric data coming from our center. I think, the government of India has taken this data also to approve the DCGI.
Sir, we are trying to have a wider study for with more number of patients. We will be starting this trial very soon with more number of patients.
Yeah.
Any other multi-center study in India.
Yeah. Thank you. Any other questions? Thank you. Any other questions? My own feeling, I think we have still how many more minutes, ma? I think we have two important studies going on across the world now. One of the study which we have started is a multicentric, and through this forum, we are just starting. So if anybody is interested, please write to me, and we'll include and it's a very simple protocol, an acute study followed by 6 months follow-up study. The acute study is for 4 weeks, and then we follow into a prophylaxis of 6 months period. That is one. The second important data which I've been very closely following, and I'm working with Dr. Ahmed who is the chief investigator for this company from Chicago. There is a multi-centric study going on in the United States and North America, including Canada. The results are not yet out, but it seems to be promising and it's comparable. So maybe at this point of time, endoxyfen needs to be tested by each one of you here. Unless you test it, you won't get it. The broad indications, I think, is clearly a classical mania or a bipolar disorder with a mixed symptoms, because for that we have evidence at this point of time from our own country. In fact, the larger, some of the investigators are here. I think Sati is here and a lot of people who have done this initial trial for us. We are proud that, this is one molecule which has come after more than 2 decades in terms of real, if you minus out the atypicals, of course. So in the mood stabilizing category, but the first molecule for PKC category. So this is the other take-home message. But surely we are too early at this point of time, and maybe this coming South Zone conference or the national conference, all of you can share your experiences. And as a PKC molecule, there are a few more molecules which are in the pipeline, I would say. And with this, I think it's a great opportunity. We should congratulate the Intas Pharma for actually bringing out a molecule. I'm not sure the youngster sitting behind will know, for developing one molecule in a mood disorder or a neuroleptic, it is now $2.5 billion. $2.5 billion. So it's really proud if this molecule can sustain. Luckily, this is a molecule of serendipity, but definitely molecule of an altered mechanism, unlike the others, though lithium and valproate are at a milder level. Any questions? Yeah. So, Anurag, I think you are receiving the prize for the best question. Please come to the dais. Doesn't matter, but that's still the best question.
Thank you, sir. Thank